Go to the ladder. The limb beds are only compressed to the surface about 1 or 2 inches, although the surface appears to be very, very fine grained. If you get close to it, it's almost like a powder down there. Very fine. I'm going to step off the limb now. Mine's just the taco. I'm trying to reach there.
HappyMentors.com.
Hello, everybody. Hola a todos. Welcome. We're going to try to play with two languages since we were used to talk in Spanish with Dr. Tapia. We're going to also talk in English because we have many people from all over. The chat, it's open. We want this to be interactive. We're so happy to have you here. As you can see, it's very cold here in Mexico City. Dr. Tapia is not as cold as me, but he's gonna do a great job now talking about FacoChop. So I wanna welcome everybody again, and I want you also to remember that everything we're gonna do is gonna be in FacoMentors.com, in YouTube, in Ophthalmo University. We have done many things. Actually, Dr. Tapia was part of this Stop at Nothing series a couple of years ago, actually, in which we talk about every single step of surgery. And we didn't talk about FacoChop that in that moment. We talked with Chop, with Dr. Wong Yung, Yamane, Rong Yo, and Takashi Ida from Brazil. So, again, there is so much content there for you to see. And more than happy to have you. Many friends here with us: Emily Villarreal, Julio Rodriguez, Karina Beltre, Javier Otarola, all great friends, great partners. They have been at the campus, and we're happy to have them. The other thing is, since we're talking about cataract surgery, we strongly recommend you to go to the podcast of Talmocast and listen to Dr. John Ferris from UK and Tom Oeting from the US, two great surgeons who are training so many people around the world. I'm more than happy to have them. And look what we're facing. We're going to face something that we really like with Dr. Andre Tapia. We see many people around doing many techniques like divide and conquer or stop and chop. But when we talk about FacoChop, there is something happening here. I think, it's a new technique. It's a great technique, as you're going to see. It's going to make you solve so many problems. But the issue here is that gap, that learning curve sometimes is tricky, is difficult, but mostly because it's high risk when you don't have experience. Let me say it again. High risk when you don't have experience, but in the moment you get experience, actually it becomes easy and you solve so many problems. And this is exactly what we want to do. We want to create this step by step, so how you can learn FacoChop, in small steps. And Dr. Tapia did that. And you're going to see it. There are going to be great videos about very complex cases that he can solve perfectly. I am completely obsessed with this, and many people, we talk about it, and many people I know, I keep talking about this. I know that to learn something like this, that is procedural knowledge, like you can see, this was wrote in 1949. This is not new. This has 70 years old. And we know that to learn something that is procedural knowledge, you need to do it. You need to practice. And it's not easy to teach you this with theory. But I think Dr. Tapia is going to do something amazing that is going to be guide you step by step at how his evolution was. Okay. And of course, then, we can have you in this simulation revolution that we're seeing. And by simulation means virtual reality, artificial eyes. So what we can do is we can start and be part of this revolution. And guess what? Learn efficiently and learn with safety. We strongly believe that you can learn a lot of surgery outside the operating room. We are, very optimist. We say 80%. I think we can debate that a lot, but we think it's a lot. And what we're going to talk about then in the middle, what's going to happen is Dr. Tapia is going to, show you many, many videos. In the middle, we're going to give you a specific way on how to learn this fast and efficiently with technology, methodology, and mentorship. And we're going to talk about this, the power of simulation. We believe that technology came here to change everything we learn. This is how we teach in the operating room, in the campus, with simulation, with books, drawing in a whiteboard, with videos, with bionic models in the operating room. There's many things that we can do. And to finish my introduction, to understand this, you can see the cataract coach was posting the other day that to master something, you need 20,000 hours of training. There is another 10,000 hour theory. What do we want to do? We want to hack that completely. We want to see and we want to understand that to be a surgeon, we artificially can divide that in three things: motor skills that are going to be very tricky for CHOP, especially your non-dominant hand doing, specific movement. We're going to talk a lot, and today is the day for the cognitive skills. We want to get into Dr. Tapia's brain and understand how he makes decisions, but most of all, how he is focused and how he's resilient when the things don't go the way that we want to. Because again, phaco CHOP can be hard. We want to talk about deliberate practice. We want to talk about having mentors and having feedback and how in a simulated environment, we can connect two brains. And for those who are interested, we're more than happy, you can take a picture of that QR code or write to us and Phaco Mentors, and we're going to be more than happy to have you there. We have a lot of people tonight. We're very happy. Andres, so happy to have you here. For me, personally, it's an honor to have Andres. Andres is a friend, is a great surgeon, and we have been together on the trench, training so many people around the world. So welcome.
Thank you, Ivo. It's an honor being here with you. I think this moment is really special for me because I've been there with you in the campus like for a year, like 2 years ago. I learned a lot there. You don't know how much I learned there. I was very happy, but life gave me another chances, and I'm now in other places. But I love Ophthalmo University. I think it is a big part of my mi camino, of my learning in the phase of surgery, and also in the knowledge. So you tell me when can we start?
Yeah, let's start. It's all yours.
Perfect. So let's see, I'm going to put my wait. I don't know what I do. Wait a minute. I have to.
Yeah, don't worry.
I can't put my
share the screen.
yeah, share my screen. Wait a minute.
Again, we can have some time for
Ah,
people.
there it is.
There you
Yeah.
go. If they have any questions, please use the chat. Usen el chat si tienen alguna pregunta. Estamos perfecto. Here we are.
So I'm going to put here my presentation.
Perfect.
And so the name of this is there. Can you see there?
Perfect.
Okay, so Chop Like a Pro. This name you gave it to this talk, Ivo. I like it a lot because this is not the one day to another day maneuver or technique. Like you said, first in my preparation of a cataract surgeon, I start doing stop and chop, and first divide and conquer, then stop and chop, and sometimes I start doing phaco chop at that time, but I thought that was really difficult because I don't have like all the structure and all the learning or all the tips for doing a good chop. So then in my when I go out of the APEC of La Ceguera, I go to a place near here that it's Cuernavaca, and there I found something interesting. I had a high volume of patients, talking about like 10 surgeries a day. It's not that much, but I have like 3 to 4 hours to finish them. So the thing here was that I have a little time, high volume, and my half of my cases were hard cataracts. So the only thing that I can do is or do it like extracapsular, that it takes me a lot of time, or try to do it with another technique that is like phaco chop, the thing I learned in La Ceguera. No? Another thing that happened to me is that I don't have M6 training. In my fellow, I don't have this, so it's not the same an M6 with in time compared with an extracapsular. So that's why I start loving this technique, and I start mastering. I started to learn a lot of tips that I seeing videos, thinking how I can be better, and I can be really, it's not to be perfect, but try to make this. I think that the thing is diminish the risks in this technique, because how you like you said, if you don't know to do this technique with a really, or if you don't master this technique, it can happen a lot of things during surgery. So why phaco chop? We know this is in the literature. You use less ultrasound power. It's a quick technique. It had a lot of repeatability when you know how to do it, and you can use it also in all cases. I do phaco chop in all cases. I do in soft cataracts, in moderate cataracts, and in hard cataracts. And this is me with my son in some years. So the tips I'm going to tell here, and the technique the tips and all that is more in hard nucleus, because if you know how to do this in hard nucleus, the moderate or soft nucleus is going to be really easy for you. So first, the tip and the sleeve. I used to use only a little part of the tip out of the sleeve, and that is not really good for phaco chop. I'm going to explain why. So because you can get deep enough in the nucleus. Okay, so my first tip is try to take the tip a little bit out of the sleeve. All these things sounds like small things or stupid things, but believe me, they are not. Okay, so now you have a bit of tip out, more out of the sleeve, and then you have to do another thing: clean your working area. So you have all these epinucleus and cortex, and when you make the rotation of the nucleus, it's all here. And if you don't clean it, you can see good where you are going to work. So this is important. Clean all this area, and then get into the right place. What I mean about this, if you see here, you have your handpiece a little bit horizontal, and you're starting to get in the nucleus, but in the center, but at the end, the tip is not getting into the center of the nucleus, and it's a little bit in the periphery. So all this area of the nucleus is not getting the force to be cracked. So this is something really important. So this is the area we want to get in with the tip. So what we need to get there, you have to verticalize your handpiece. That is really important. You're going to see in my videos how my handpiece is a little bit vertical, so for getting inside, like near your axis, or more near your axis, for the end of the tip, for being in the area you want to crack, or the area more hard of the nucleus, that is there where you want to be, deep into the center. Then the parameters, I'm not going to talk about the parameters a lot, but the thing here is really important to use longitudinal ultrasound and high vacuums. What? Because if you use torsional, you're going to make like a big hole, and that's not going to give you a good hold. So if you use longitudinal, you're only going to do a really thin hole, and the holding is going to be better. And the other thing is the high vacuum. It depends in the logs, but you can use in hard nucleus 400 or more. Okay. Now, some things happened to me sometime, and the things I see with my fellows is the left hand. The left hand, you have to start to working with them at the beginning. I tell my fellows and the residents that the left hand is really necessary in cracking the nucleus. So what happened at first? Misposition of the chopper. You are afraid, you think that you are there, and you go here, and this can cause a disaster. So that my tip here is to enter brushing the cortex. I call it like that, like you touch the cataract and you push to a place of a safe place, and you will never have this problem of hitting or to the sonule. So you brush the cortex and you go to a safe place. But then what happened? You have fear. You have fear because your left hand, you don't want to go that deep. You don't want to break the posterior capsule, and you make something that I'm called wick chop. You don't go that deep. You may have your handpiece well placed, but if you don't go that deep, you make a wick chop, and this is with the thing that all the fellows and the residents struggle a lot at the beginning, because they do a wick chop. They only are in the upper part of the nucleus, and this is going to never going to break or make a good fracture. So what you have to do, good left hand, train your left hand, don't have fear, and go deep inside. Why is this? Because you need to break all this force, all this hard nucleus, and the only way you can do it is going deep with your left hand with your chopper. So then you are in a good position with both things, with your handpiece and with your chopper, and you start to do it concentric force. Another thing I have seen with my fellows and my residents is that the right hand, the handpiece, doesn't only hold; they move it. And what happened if you don't do the concentric force with your left hand and start moving your handpiece? Remember, the handpiece have with a hold in with vacuum, with high vacuum, is you're holding all the nucleus, and it's a very dense nucleus. So if you move your right hand, you're tractioning all the sonula from all places. If you traction up, if you traction down, if you traction left or right, you're going to stress your sonula. So your right hand is only to hold all the nucleus. And your left hand is the one that have to do the job, okay? So with your left hand, with your chopper, do it slow, let the chopper work, and increase the strength little by little. How the movement of the chopper also is really important. I'm going to talk about it. And then what? The climax, the fracture, the thing that we love. So also very important. All these are tips from my experience. This is why I do what I do. There are another choppers, there are another instruments that are good for this, but I use the Sable chopper because of these things. The angles are really good for working where I want them to be. You have a sharp edge in the part that it's going to touch the nucleus and break the nucleus, and you have another part without sharp that is really secure to work with, touching the back, the capsules. So now the incisions. I like to work with incisions at 90 degrees. Some other doctors I see that close them a little bit for do a more vertical chop or something like that, but I like to do it, and I tried different ways to do it, and I like them at 90 degrees. Ivo, if you want to tell something, or ask something, you can. All right.
No, I think it's amazing what you say about the climax, because to chop, it's something incredible. You know, sometimes it takes us to our primitive brain, and when you chop, when you have that capability to crack the nucleus, you know you're saving so much ultrasound, but also it's an amazing sensation, and I think everybody should go to do that. I'm thank you for asking, because I'm gonna put to vote to the guests to vote. I really want them to ask questions and to see everything they are doing, and we want to see which is their preferred technique. Okay, and I think that's going to be very important. Again, we're going to talk about fundamentals. Some people go to the real deal and they want to see videos, they want to see complications, but it's so important to go to the fundamentals. If we don't understand the fundamentals, especially in this technique, it's not easy to master. So I'm going to give many people responding. You know, there is people still missing to participate. I'm going to take 15 more seconds, guys, please. Okay, almost there. And the results are going to be great. I'm going to share the results soon. What do you think? What do you think people are going to answer, Andres?
I think a lot of people love like Stop and Chop,
Okay.
because you have like a part of something of security and also a chop, because that it's a chop, Emmy chop, but it's a chop. So I think many, but I have seen that a lot of people want to learn Faku chop. So
I know. Yes, many people, and again, then we're going to talk about how much you can learn in a simulated environment. Let's finish the votation, and I'm going to share the results. Actually, I'm going to take a picture. Okay, pretty sure you guys are seeing the results, and very, very interesting. What do you think? Actually, it was almost a tie. Stop and Chop won with 38%. Okay. Then Divide and Conquer and Faku Chop were very close, but the second was Divide and Conquer. The third one was Faku Chop. And I'm very impressed because I'm a pre-chop, as you know, a pre-chop lover. So I'm very impressed about people not using pre-chop. And the other thing is, in the future, we're going to do an entire webinar for vertical chop. because again, vertical chop, I think it's more challenging. However, vertical chop also helps to save so much ultrasound. So please continue, and people are already asking for your videos, Andres.
Okay. So I'm going to go a little bit fast. I'm almost finished. But the left hand is really important for you to master, because you want to go your chopper this direction, and the thing that I see many people do is this movement, and you know that your incision is not there, so you're hurting your incision, you're hurting your cornea, and you're never going to make a good chop doing this movement. So what the movement your left hand, your chopper, need to do is first going out of the incision for doing this first, like out first, like this, but then you need to pivot your chopper outside for the force to go to the inside, and get your chopper also a little bit outside, and that's the force you need without hurting your cornea. This is also important now with using you're going to see in one video using low IOP phaco, because the cornea is really with a low IOP, so it's really easy to hurt the cornea. So the tips of this is really easy. Know your limits. Start with moderate chops. Expose tip and clean the area. Vertical handpiece, go deep. Verticalize your handpiece is really important. Master your left hand for no weak chop, and concentric force with chopper. The handpiece, remember, only holds, and that's more important in really hard cataracts. So I'm going to stop this, and I'm going to show the videos, and we can discuss all the videos. There you can see my presentation. You see there, Ivo? I think you're...
Oh yeah, sorry. No, I was saying that we're waiting for the videos. Anais is saying that she's waiting for a pre-chop webinar. So we're going to do a pre-chop, and then we're going to do another one with vertical chop.
Nice. So here we go with some videos. So look how my right hand is really vertical for getting into the center of the nucleus, deep inside center. And look my tip, how is really exposed. There I go, my left hand. My chopper goes out, and with the pivot movement, slow and easy. Without moving my right hand, I get the crack. Look how here I use 30 of IOP, so my cornea is really easy for getting with some wrinkles. Then you have to try to get all the chop all the way around. There you go, and then you do some Emmy chops. What do you think, Ivo?
Yeah, let me do. Can you put it again? Let me do a couple of comments, because it's I see so many things. The first thing I'm seeing about is how hard that cataract is, and oh my God, I'm getting scared, because that's not only a hard cataract, but it's also I'm thinking about a diabetic patient with a posterior plaque. Those that if you sculpt, they're so hard to crack, and you stress the sonula so much. The second thing is you're doing your incisions at 90 degrees, which I like, and also you're chopping a very hard cataract with a sable. That means that you don't need a sharp edge like a Nakahara or a horizontal chop in order to chop if you're doing the technique correctly. And that sable is very safe. And especially because one of the things I say is you need to be careful with your second hand, even when you go inside the paracentesis. You can hurt the incision. You can hurt the anterior capsule. You can hurt the posterior capsule. You can damage the sonula. So the other thing, put it again, Andres, because there is something I love here, and that shows how much experience you have, is how relaxed you are, how gentle with opposing to the two forces, but because I can see the tension that you're
And
feeling.
listen,
is-
I stop my pedal when when I have the concentric forces. I only irrigate. That's
Oh,
it.
okay. But you see, right there in
Yeah.
that moment, you're feeling the forces, right? And that's the
With
key.
this,
And
with
also,
this,
you cannot get superficial. You need to go a little bit deep into the
Yes.
nucleus.
with this grade of cataracts, you can feel when it's going to crack or when it crack. So it's amazing. You can feel it in your fingers. So, but yeah, it is the thing that I the thing I said is that do it slow, and it's going to be better because you can feel it, and you can stop if something is moving something wrong. If you do it quickly, it can be a disaster. No.
Yes, and I think you're breaking many paradigms here. First is that you need to make the incision in less than 90 degrees because you did it perfectly. Second is that you can chop a hard cataract with sable. The third thing is you're chopping a hard cataract, in a very safety way because you're waiting and you're very smooth with the forces. I really like this video.
Okay, let's see.
Which vacuum did you use in that case?
When I have cases like this one, like this I use like for 450 or maybe 500,
Okay,
more or less, with a
great.
high expiration flow, and that's it. Here I have another case.
Since you're showing the capsulorhexis, any tips about capsulorhexis? Because
Yes.
when I chop like that, I like big capsulorhexis, right?
Yes, for sure. I also like big capsulorhexis for this. In every hard cataract, I prefer big capsulorhexis, but the thing here is I have a small pupil, so I can't do it that big. But I try, and also I have some capsular fibrosis, but I managed to do it the bigger I could, and it goes well. So let's see. So I have problems with here with the
What about staining like you did? What about staining the capsulorhexis? Because one of the key things is you like to put sideways chop in order to enter more comfortably, because also the other thing for chopping is when you're chopping a soft cataract, sometimes you get the luxury not to go that periphery, because you want to chop the nucleus. But
yes,
in
yes.
these cases you're showing, you need to go to the periphery, right?
Yeah, but the thing is that how I do it here is sometimes I don't see the rexis, the border of the rexis, but I entering like I said, like brushing my cortex, and in that way the chopper is in this way. So if you brush the cortex, you're gonna enter inside the bag. There's no way you go out. So that's how I do it. I
So
sometimes
let me understand that you feel with your second hand that the chopper is touching the lens.
or see if it's touching the lens, like you're going to see here.
That's a good tip. That's a very good tip.
So I clean the area. I think here also I want to tell is you can see this cataract with some color, but more opalescent, and you're going to see how the opalescence is not sometimes doesn't tell you that it's going to be a hard chop, but the color does. So this is important because see how this chop is not that hard, like another one I'm going to show you in the next video. So the chopper, look how it enters. I don't see there the border of my rexis, but I can see it. But so I enter there, hold, and there I enter. And look, the chop this is not that chewy. The chop is so you with experience, you learn which cases are going to be hard to chop and which others are not going to be that hard to check.
So which case would you say this is going to be hard?
The next one I'm going to show.
The next one. Oh, I like that.
And also I have a picture, a a picture before the surgery of the nucleus. So this one goes well. It's not that hard to chop, but it looks like it's really hard, but it's not that hard. And you learn how to see that. That's interesting. This case, okay, is not that white, it's not that opalescent, but look the color. And when you see this color, when you see like I said, like cueroso, or like a brick, it's going to be difficult to chop. So this case is a post-vitrectomy patient with this. Look, you at the first, it also have like red reflex, but look the color. And with that color, this chop is really hard. Really, really hard. It goes well, but it's really chewy. It's really hard, and and it's also a cataract more difficult in quadrant removal, because the pieces are more like fibrotic. I don't know.
No, yeah, I know. It makes total sense. And especially, let me talk about post-vitrectomy. Do you have any other issues that you think
Yes.
add to the chopping technique itself?
No,
Meaning
to
that
the chopping technique, no. It in this case, I had a problem that all the blue went to the back, and I work without red reflex after putting the blue. But in this case, no. It doesn't work. It doesn't go like a big shallow anterior chamber or anything like that. It was a good case, but sometimes you can have that problem if you have a big eye with a big post-vitrectomy. You can have problems getting in and with your chopper, because it have a really big anterior chamber. But besides that, I don't think so. In this case, it goes well. So this is the hard the color that you have to be careful of for chopping. This is another case with a really hard nucleus. The same. Look how how vertical is my right hand. Is really vertical for going really inside and not superficial. There I go with the chopper, and something strange happened here that I have seen with this chopper, because I have like 4 sables, and with this one, it bends a little bit before the fracture. There. So it helps a little bit, I think, with the force for fracturing. I don't know. I always try to make the other side fractured, because that's going to help for the other ME chops, and also clean the area for seeing if there's a good cracking or you need to do more.
Any comments about the sables you use any brand in particular?
This one, I like it a lot, and maybe it bends a little bit, but I think that work also because of the memory of the steel, and it make like a wipe for fracturing. This one is the one from IKEO from Mexico. It's a really good sable chopper, and it's really cheap. So I like that one. The other one I have is one of Rain. It's more expensive. It's a good one. But the thing is that they need to have sharp in the inside if you want to do these cases. It's not that sharp like another choppers, but they have a little bit of sharp in the inside. So this case is a little bit more complete. I like to do a lot of chops, because if you make a lot of fragments, you don't spend that much ultrasound, and when you start quadrant removal, it's easier, a lot easier if you have like a pizza, like 8 or more pieces. But also, you tell me if we are good of time or if you want to comment something.
No, please, yeah.
This is another case, but it's how I do with chopper. Also, not hard cataracts. The thing I did here is it would eliminate for me to have like the golden ring and do a small chop, like you were saying that, no, like you don't need to go too deep when you have a softer cataract. So it's also a really safe technique, I think. And look how it's a lot more easy than in a hard case. I don't need to expose a lot of my tip. You don't need that much force, and you can only do that and only do one chop and start with aspirating all the ME fragments, and that's it. But it's a technique that you also can use for not hard cataracts. It's a really easy technique.
Dr. Julio Alberti, who is here with us, is asking which cases would you recommend to start? A case like this, for example?
Yes, this or like more a little bit more hard nucleus. It's easier because in this part you have to aspirate the epinucleus, and sometimes it's a little bit tricky because I hydrodelaminate. The best is like grade 3 cataract is the best for starting because it breaks easy and you don't need that much power to or force to make the chop. This case is also something I want to show that why I think Phaco chop is a really good option to learn, because if you know your movements, if you know how to chop without seeing your border of the rhexis, if you know how to do all that and you memorize all your movements, you can solve cases like this one, in which you can see all your rhexis, you can see all the border of your rhexis. You're like in a blind place with blind places. But the thing you have is these 2 windows, and in those 2 windows you can see where you're going to enter and do the movement, and try not to search in the places that you can see, but see the places you can see and imagine what is happening in the other places and do your chops. The good thing here is that it's not a hard cataract, but knowing your movements and your technique, you can do it well. And this is one of my hard. Is the video you sent to the WhatsApp groups? I think this case, I know what you can think. It may be, it's a lot. I think this case, maybe this is not the best technique for do it. Because look how the chop is hard. But the thing here is that when I start doing the chop, start not to getting frustrated, doing a lot of chops, like 10, 20, I don't know how many chops I did there. Then when I start to get the quadrants removed, they go the phacomulsification went really well with the parameters I had. So this case, it looks like really difficult, but at the end it goes really well. Because if you see here with the chops, I'm trying, doing a lot of chop, many times. But then there, I got that piece out. and look the quickly that the machine get them. And there you start to making some space without frustrating yourself, and look how the fragments goes really, really good. Well, high vacuum, good parameters. I think that's another topic, because it's really hard to get to the best parameters. A lot of visco. This was a patient like 55 years old but diabetic. So the endothelium was really well. That's the other thing. You have to choose really well your patients that you're going to do this technique, because the endothelium needs to be really, really healthy. But if you see, the ultrasound do its work really good, and it went well. I also like to do the shield technique with my left hand with the chopper, protecting the endothelium.
So one thing I like, and people are asking, for example, Doctora Valeria Valero is asking, is you prefer to chop a small fragment, and when you know that it's divided, do you like to remove it before you keep going, or you like to chop
yes,
in many places?
It depends. Sometimes I'm like, why now I get that fragment, and why sometimes I make a lot of chop. I don't know. It depends what I'm feeling in that moment. I don't know. I can't tell you what is better, because sometimes I get one fragment out for getting more space, and sometimes I like to make a lot of chops and then getting them out. I think the important thing here is that it really difficult to chop. If you have one fragment loose, you get it for getting more space, and maybe to calm down a little bit, because it's frustrating when you have you're chopping and you don't have any fragment out. So, and when you can make the chop and you're doing it with and you're in the flow, you let them there, you do a lot of chop, and at the end you start with the quadrant removal. Also, because I change from quadrant removal and chop when I do chop, and when I start with the fragment, so I need to play with my pedal.
Perfect. Yeah, no, Dr. Julian Lozano, also a great friend and a veterinarian ophthalmologist, is asking, how comfortable you feel, because in veterinarian, especially in dogs, cataracts are so hard. So the chopping technique for those kind of cases, it's so important. But yeah, keep going. That just by seeing that picture, I'm getting excited.
This is one case that is special, because it's different, and I do it all wrong. Also, in seeing what I didn't see this in the pre-op. Also, I make a bad movements here. I don't enter with all the materials I needed in this surgery. So this is what happened. So the blue, look, it goes first. The blue goes to the vitreous cavity. Then when I take the cortex, it's a really hard nucleus. Then the rexis here is really, really small to the border. So then what I'm going to do, okay, I know here I have a big sonular weakness. No weakness, or no sonula there. So I put this tension ring, but the thing here is that it will be better to use as a med segment or a modified capsular tension ring for suturing to sclera. But I don't see it. I don't saw it, so that couldn't be done. So I tried to use also iris retractors, not back retractors, and I tried to do a phaco chop. That was an awful idea. So there you go. So I said, no, you have to know when to stop. I said, no, this is not the way I have to do it. I'm going to convert. And this video, I put it because I also convert many surgeries. I do a lot of hard nucleus surgery, hard cataract surgery. But when I try two chops and I see that or the sonula is weak, or I can't do it well, like this case, I go to a extracapsular. That's the way I do it. And in this case, I do that, and everything goes well because I think there's some vitreous. I try to stop it with the nucleus. I get it outside. And another error that I made here is not closing. This is really important, and get this. You have to close your eye really well for doing a vitrectomy. But okay, I only did a little bit of vitrectomy. Close, put the three-piece IOL in its place. Look, all the blue in the back because of the sonular. Put the IOL and do a more vitrectomy. Also, here you have to close your incision for having a good vitrectomy. But okay, I did it wrong, and it goes well. But
You put a, I didn't see, you put a 3-piece IOL, right?
yes, three-piece IOL, yes.
Yeah, okay. Perfect.
And it goes
actually
well,
was very well solved.
Yeah, but you have to know when to stop.
I think that's the main takeaway. I really like you show this, Andre, because that's you need to know your limits. You need to understand, and I think you really make a good way. Say, okay, I try to chop, and I see a lot of instability. I stop. Period.
I stop, and there's some resolutions. There are some ways for do it better than only chopping in if it's not going well. So don't think Phaco chop is everything. We love it. I love it. It's my favorite technique. But you have to know how to convert surgeries.
Very nice. Can't agree with you more.
And this is, I think, the last video. It's another hard cataract. The same. I'm going to repeat to the center. A lot of tissue here you want to break. So you go slow. And then here you pivot with the first, this go up there, this goes to the other place, and that's it. There you go. You have your.
When I see that hardness and I see you waiting for the right moment to do the movement, I try to imagine what it will take to sculpt that, because oh my God, that's hard, you know. So it's I love chopping these kind of cases because many people will go to an extra cap from the first minute. But as you go slowly, you take your time, you're making the right decisions, and you're putting a lot of dispersive viscoelastic.
Yes.
I'm pretty sure that these eyes next day are 2020, 2030.
In this case, I have a picture from the post-op. Look, this is true. Look,
I know.
But in this case, I use a lot of, in all my cases of these cases, I have a limited dispersive visco. So when I have a hard cataract, they give me like 2 or 3 of dispersive visco, and I use it every 5 to 7 from ultrasound. This is a Centurion, so is the CDE. But look, it goes well, easy. You protect your endothelium, and everything can go really well. And at the other day, this is the cornea the other day. So you can do it. You can use this technique and have excellent results at the next day. Not all my cases are like this, for sure, because it depends also in if the patient is with a good endothelium, the age of the patients. But I think also M6 and extracapsular have endothelial loss. They are not like, if I don't use ultrasound, it is not going to be endothelial loss. Also, they have a lot of manipulation. So I'm team Phaco chop, but you need to know when to stop and convert. That is the thing I want.
And also remember, I know when you see this kind of patient, probably they're diabetic, they have many other issues in that eye. And when you do a control and you take more time than a regular cataract surgery in phaco, but you do phaco and you take your time, that eye, you can do a trabeculectomy afterwards. It's gonna dilate perfectly, you can do a pen photocoagulation. I mean, there is a big change between doing M6 that I know many people are great on M6 and do great jobs there, but I strongly believe that if you do phaco in this kind of eye and you
Yes.
take your time,
Or use Torix also. You can
Oh,
try to
no,
use Torix.
exactly.
So
Let me just, we have 5 minutes left, and I'm gonna share because we have, for example, here Anais Linares, Anais, I hope you're doing great. She's saying that she wrote to Santa the letter to go to the campus. I'm pretty sure Santa is gonna make that happen because, good things need to happen. If you can stop sharing your screen, Andres, I'm gonna share
yes.
my,
Sorry.
don't worry, I'm gonna share mine, and I just want to show one video because this video is gonna be powerful. The first thing I want to show is that this video you can access afterwards in fakementors.com and in YouTube. There's many videos there. For example, we post a couple of days ago the blanco puncture technique for white cataracts, which is amazing, a new way to um, access white cataracts. But in this case, I'm going to show a video with a simulator. And the first thing I want you to see is fidelity. Okay. Again, you saw the eye, the many eyes that Andres showed. And here I'm going to show you what the simulator is looking like. But I really want you to pay attention to everything, to all those things that are next to the simulator. The first thing is gonna ask for you to remove epinucleus, and it's gonna tell you which percentage you are removing. That's something Andres talked a lot about, and he does in order to identify the nucleus better. When you remove that, the simulator is going to tell you, okay, here is the nucleus, and that's a green spot where you really need to go and do the phacoemulsification and the holding. But the great here thing is if you see that image here, upper image, you're gonna see everything that is happening in the eye laterally. And here you can see the nucleus that is right there in order for you to go to the nucleus. How many times did Andres say that? How many times did he show you, I'm going deep. I'm going to the nucleus because this is a hard cataract and I'm going to push the two forces. So, in this case, I'm going to aim for that green point, and then I'm going to do the 2-3-2, which I like to, it's like I'm going to do aspiration, a little bit of ultrasound, and then go back to 2 to do the holding, and look at that. The nucleus is going to turn green when you have the holding. If you lose it, like there, for example, look, it's going to be lost a little bit. It's going to turn red again. You see? Now it's not green anymore. Now it's red. Now it's green again. And the machine is going to tell you exactly the line and how vertical the second instrument needs to go and how deep you need to go. When you're doing that maneuver that Andres does a lot, you have two arrows that are guiding you to do it perfectly. Then you rotate. The white part is going to tell you, you need to go here because here is the nucleus. You need to do the 2-3-2. You need to make that turning green. That's red. That's green. And then you need to go through the line. And remember, one of the keys, you need to go deep and then do that maneuver to the sides. You now only look the side view. Look at the side view, and you're going to see the right position for the handpiece and for the second instrument. When you see these things, your brain actually makes this mental model, this mental map of what's happening. Look at that beauty. You go, stop, you see? So guess what? Simulation is going to make this possible. Look at what's happening now. Those fragments are turning green or red if you are in what we call the safety zone. If you see that, Yeah, sorry, but that white, like round there, right there, that's the safety zone. So you can eat the fragment with no problem. If you're outside there, it's gonna be red. Why? Because you're doing fake emulsification 2-up. You see green if you're in the safety zone. But the other thing you can simulate, and I really want to talk about it, is when everything goes wrong. Look at that. You need to understand that when you enter the eye, in this case, one of the things that can happen is you can go too deep. You need to understand the second instruments. Look at that. I'm showing you a chopper with that is sharp, and then another kind of chopper. So in your simulation activity, you can use different instruments. Andres made the point that he could chop with the sable, but you can use others. Okay, that's very important to show. And there is many things that can go wrong. For example, one of the things that you need to be more scared of is exactly that. I hope you can see it right there. In that specific moment, the surgeon is going to go too deep and what happened? He went too deep and he had a posterior capsule break. Okay, since the beginning. That's a big issue. The second thing, you can damage the endothelium if you not understand that. Third thing, you can damage the anterior rhexis. And fourth thing, if you could see there, he went too deep in the periphery and damaged the posterior capsule also with the second instrument. Also, if you push too hard and the sonula is suffering, your fragments are going to say bye-bye, like exactly that one, that you're losing that fragment, and again, many other things that we can train, but specifically here, for example, something we can talk in the future is some vertical chop. How vertically also, you need a new instrument that you can chop in different ways. So again, Andres, it was great to have you so much. 1 hour as we like, one specific hour, a lot of knowledge. Every time we open our mouth is for somebody to learn something. You can find his Instagram account. Please tell us your Instagram account because it's amazing what you're uploading from videos.
I'm going to put it in the chat.
The chat, and I hope we can have you with us in the future, and all the people who were with us. Thank you for your time. I know everybody's very busy, but to give you some time to learn something new, it's really important to grow as a surgeon, right?
Thank you, Ivo. Thank you. And that the thing you showed, I would loved to use it. The chopper machine. It's beautiful. I hope you all try it. Okay.
Okay. So thank you for your time and hope to
Thank
see you
you.
pretty soon. Okay.
Bye bye.